It's 1 o'clock, and I will want to make sure that we respect our time here. But I want to welcome everyone to today's grand rounds. And I will introduce to you our speaker for today. Selene Vences we've known each other for years and been part of a mentorship relationship for many years now. But she is a PhD student in the Department of Environmental Health at Boston University School of Public Health and a current Robert Wood Johnson Foundation Health Policy Research Scholar. Her research interests include investigating the environmental mechanisms and community-level drivers of chronic kidney disease of unknown etiology in Central America, health effects of heat, the built environment, and occupational exposures on human health throughout the life course, using mixed methodologies to generate targeted interventions and implement policy changes. And so at this time, Selena, I would like to pass it on to you.
Thank you so much, Dr. Chavez. He has been a wonderful mentor of mine, and I feel very lucky to be here today to present to you all. Before I do that, I'm going to drop some links in the chat if you have access to them. Great, and if not, I'll email them to Tiffany after the presentation. Okay, so for the presentation today, I kind of wanted to start thinking about health. Among vulnerable populations, more from a migratory perspective. And so, kind of woven throughout the presentation, I'm going to give you personal examples from my family, and also from my time while I was a community organizer. Um, and I'm happy to answer any questions, provide any additional resources that you have. And without further ado, I'll just keep going through my slides. I do not have any disclosures to announce today. And just an overview of our agenda for today's presentation. So first, I'll give you some background as to why people are undocumented, specifically in the context of the United States. Then we'll talk about undocumented families in healthcare and healthcare access. And then chronic kidney disease of unknown origin or unknown etiology. It goes by many names, including Mesoamerican nephropathy. And then at the end, we'll put it all together. And here I'm talking about exposures and health through the life course. So the general thread throughout the presentation is to have an understanding that health and health states exist as part of a complex network that is shaped by social, cultural, and systemic factors through someone's life course. So what I mean by that, this includes when so in the womb all the way till they're 99 and they pass away. And the reason why I decided to use exposures here is because in environmental health, we consider exposures those that are physical, chemical, biological, and radiologic contaminants in the environment. However, here we're also considering policies as and adverse experiences in the exposure health outcome pathway. Okay, so these are the three learning objectives. I'm sure you guys have them as well. Understanding healthcare access among undocumented mixed immigration status families, experiences when accessing healthcare among these families. And in this, for learning objective number two, I'll use a project that is very near and dear to my heart and how I first met Dr. Chavez. And then I'll also provide some insights onto CKDu and the mental health experiences among youth living in a high-risk region for CKDu. Okay, so like I mentioned, before we begin, I would like for us to kind of take a step back and without judgment, really think through why we think people are undocumented and why people are undocumented. So that could be the same, that could be different. And I do think that this is important to start here so we can gain understanding as to why people are undocumented in the first place or how someone becomes undocumented. And I know there's been an increase in enforcement, and I'm sure it touches on everyone's lives because whether you know it or not, you may know someone that's undocumented and they might not be comfortable to reveal their status. Or you yourself might be, or you might come from family members that are undocumented. So, first, to start understanding why people are undocumented, I want to go through the push and pull theory of migration. And so, So essentially, what the push and pull theory of migration says is that something, a factor, is pushing someone out of their home country, and something else is pushing them into another country, or these we consider factors. So, for example, political persecution. When I was a caseworker, I worked with a man that was from the Middle East. He was a journalist who had his teeth pulled as a form of torture and political persecution, and he and his some of his family members had been killed as a result of his journalism. So that's a factor that was pushing him out of his home country. Others include violence, trafficking, poverty, and climate change. Um, and another factor that we did see, especially as it relates to corn in Mexico, is globalization or trade agreements such as NAFTA. Now, something else is pushing them into another country, right? And the idea here is that people don't migrate to a place that they may not know, unless the place that they currently know or their country of origin is less safe than some other place that they have never been to. So I kind of want you to put that into understanding. If you felt persecuted and if you had no other choice but to move to a foreign unknown country, you must feel pretty unsafe in your current country. And the important thing here is that these push factors don't care about timelines or waiting in line, because immigrants who are fearing for their safety will do what they need to do to protect themselves and their family members. And a lot of times this is through migrating. So, pull factors here include prospects of economic opportunity, networks, safety, educational opportunities, and perceived improved quality of life. Now, I have heard during my time as an organizer, and I just want to take a little bit of time here for you guys to kind of look at this chart and take it in because it's very busy. um the idea of like, well, why don't they just wait in line? Why don't people why do they migrate the unauthorized? Why do they migrate the way they do? And the reality of this is for a lot of people, there is often no line. So there is no available pathway for undocumented immigrants through regular channels. And as a result, they do end up entering through unauthorized channels. Even though most immigrants in the United States have been living here for over 10 years, a lot of them are not eligible for to adjust their immigration status. A good example of this is people who have deferred action or DACA, deferred action for childhood arrivals. A lot of them were brought here as children. This is the only country that they've known, but they're still unable to qualify through most of the means highlighted here. Um, the pathways that some people have been able to adjust their status, including some friends of mine, have been either through employment, family reunification, or humanitarian issue protections. But these are heavily regulated and subject to numerical limitations and quotas from countries that have high migration levels. Okay, so I am showing this information here just to highlight how many people are immigrants in the United States. So in 2015, 2025, sorry, there was the most amount of immigrants that have been in the United States at 51.8 million, so roughly about 15.4% of the United States population. And the reason why I highlight that is to kind of show you what this immigrant population in the United States looks like. I feel like a lot of the focus is often on the most vulnerable, and they're often the most criminalized, which is unauthorized immigrants who now make up 27% of the immigrant population, or 14 million. But there is also a lot of naturalized citizens, lawful permanent residents, and people who are temporary residents. For unauthorized immigrants, we are also including people that are DACA recipients or that have temporary protection status, or TPS, as you all know, that has been revoked for a lot of countries, including Haiti. Okay, so why do I want to bring this up? I want to bring this up just to kind of for you to have an understanding of, okay, why do people migrate? What does the makeup of migrants look like in the United States? to then get you to think about, okay, what do these families look like, right? Some of them are what we call mixed immigration status families, which means that within a household, there could be people that have different immigration statuses, such as one could be a US citizen, the other one could be undocumented, another one can be a legal permanent resident, and so forth. And so the reason why I highlight this is because the barriers faced in within a family group is not the same by each family and among each family member, meaning that healthcare access might be different for family members. If there's a sibling pair, one of them's undocumented, the other one's a US citizen, their access to care might be their healthcare eligibility, I should say, might be different. Their access to care is another thing that I want you all to think a little bit more about in my next slide. Okay, so, and I'm sure you all are familiar with this here, but I want to kind of highlight some barriers to healthcare. So I'll highlight policy, financial, and then economical, and a few others. So the first one being insurance eligibility requirements. One of the links that I shared with you all is from the New Mexico Center on Law and Poverty. And that link kind of shows what undocumented immigrants are and are not eligible for as it relates to healthcare. As we know, most of us get our health insurance either through school or through employment. I wanted to highlight in that document there is a one small portion of relief during for emergency medical services, and it's called EMSA. It's Emergency Medicaid Services for Aliens. But you all can kind of look at that document and kind of have it as a resource. Also, too, a lot of undocumented immigrants are ineligible from federally funded programs, including CHIP, ACA, and Medicaid. Now, here, I kind of want to stop and really get you thinking in that the child, let's say that a parent, a household, a mother and father, and a child. The mother and father are both undocumented, but the child is a US citizen. Oftentimes what happens, and I saw this a lot while I was a caseworker, is that the child is eligible for services, but the parents are not. So what'll happen is that the child will have health care. Maybe they have CHIP because they themselves are US citizens, and the child themselves may have access to food stamps, right? But what happens is, and this gets at the next note for public charge, is that the parents are fearful that any applications or any aid that they get could be seen and deemed negatively on an immigration application. And so therefore a lot of parents don't actually take advantage of these programs that their US citizen children are eligible for. And as a result, a lot of US citizen children that are in mixed immigration status families live undocumented lives. And this is important too because recently, oh, not recently, sorry, last year, there was a change to the public charge rule here, where certain benefits would be deemed as would make immigrants inadmissible to change their immigration status. So because they changed how the public charge rule is defined, this leaves more ambiguity, and now an immigration officer can deem Head Start programs, free school lunch, or even care at a certain community health centers as very as inadmissible instances for immigration status. And so I think this will create even more fear and more worry among children. And I think this is especially heinous because these are programs that free lunch a lot of children that are low resource and low income often need to kind of grow and develop. Okay, other barriers is insufficient income-based programs. They're often not enough. At a high out-of-pocket cost due to not having health insurance and lack of employer-based benefits because undocumented immigrants sometimes work under the table, get paid in cash, or don't have permanent employment. And then there's also the triage of poverty, which is when families are forced to make difficult decisions, such as do we pay for this doctor's visit or do we pay for mom's diabetes medication or do we pay for rent? Oftentimes, those choices is where healthcare loses. Another example of this is where there was a mother with sick children. She took the sickest child to the hospital to kind of get the child treated. So then, based on the treatment that the child gets, she could kind of then do home remedies to try and bring in the other children back to health. Okay, there's some institutional barriers. These include lack of knowledge in healthcare services, identification requirements. So let's say, I think New Mexico and some other states, including Massachusetts, they're a little bit unique in that undocumented immigrants can get licenses and or they can get state IDs. However, it's not a real ID. And so there is still that little bit of fear of like, okay, well, if I don't have this yellow star on my card, they might know that I'm undocumented. But some people don't get any type of ID. And so if they go to the healthcare facility and all you have is their passport card or their passport from their country of origin, it does create some uncertainty around if whether or not this person can be identifiable or themselves revealing their immigration status. The other thing is increased immigration enforcement in healthcare settings. I'm not sure if you all have experienced this or are familiar with this, but there has been instances of immigration officers staying while healthcare providers are performing medical procedures or refusing to remove handcuffs from someone that was detained. And so as time goes by, we have been seeing an increase of this more and more so. Um, okay, so other barriers include linguistic barriers and sociocultural. So because of the lack of healthcare access, because of the out-of-pocket cost, a lot of times mental health care is often left behind when there are more chronic or immediate health concerns due to resources and knowledge. And I think this is really important too, because in a lot of families, you need your diabetes medication or you need certain medicine, but oftentimes it's like, well, I am really anxious. Maybe I won't spend these extra dollars on my SSRI and get something else if they even understand or have that access. Or sometimes they do self-soothe, whether it's through alcohol or cigarettes or other means. And there is also language access barriers, specifically with inconsistent medical language access, or access in their language, so Spanish, Vietnamese, Mandarin, things like that. And here too, I also want to point out that treatment is often difficult to understand, or the patient may feel uncomfortable asking questions to understand care. So I'm my grandmother's medical power of attorney, and also for my grandfather. So I make all the healthcare appointments. I go to the appointments when I'm in town. I talk to all the healthcare providers. I message all the providers. My sister and I, we have our own calendar to manage my grandparents' care. And sometimes what happens is I have to write letters to my grandma that then she takes to her healthcare providers. So then I can explain what she's there for and the ailments that she's had. And so, or the things that we would want her to be screened for based on what we know from her medical history and what she's telling us. And because she can't read in English, and so we send them to her, give them, and hope that she gives them to the doctor, and then hope that the doctor reads them. Other things that we do is that she'll call me while she's with the doctor and she'll say, I don't understand what this person is trying to tell me. Can you please talk to my granddaughter? And so I laugh because my family and I are so used to doing this, but I know that this isn't normal. And I wish my grandmother could have the support and the care that she needs, but oftentimes that is not the case. And my grandmother does get her health at a community health clinic. And so I repeatedly have asked her primary care provider to screen her for anxiety based on how like her hair pulling and just the way she talks and the symptoms that she's telling me. And her healthcare provider is refusing to do so. And so that's something where the self advocacy, she can advocate for herself. So my sister and I advocate for her. And so, along with that, I also want to point out that there can be mistrust in the medical system for multiple reasons, as you all probably know historically and at present time. And of course, there's cultural differences in healthcare seeking behaviors where I think for us, for my grandmother and my grandfather across a span of 15 years, we have made them feel comfortable going to the doctor, but it's taken a long time because a lot of the times they just kind of wanted to treat things at home. And what that did is it just prolonged care and it made their current condition worse. Okay, so what are the consequences of this, right? So delayed care at the expense of costly emergency department visits. So you wait until until it's the absolute last straw, absolute last line. And I'll provide more context on that later. And then we also have complications due to treatable chronic diseases. So, for example, a couple of my friends' family members have very high, they have bad hypertension that went untreated for so long and it got to a point where the loved one ended up in the hospital, and now they have to do these extra mitigation efforts to try to bring them back to health and shorten quality of life. Okay, so now I provided you kind of a history of barriers and different examples of barriers, but now I really want to contextualize that specifically in New Mexico and what health and mental health amongst this population looks like in these families. And so to do this, I'm going to use a study that we conducted. At this point, it's been like 9, maybe longer years, but it's still relevant now, even more so than ever, because at the time there was still some protections and things were not as terrible immigration wise as they are now. And so I am first going to go briefly through the methods and then kind of the findings and discussion and implications for health. And so this was part of a study across three different areas in New Mexico using snowball sampling. All youth were mixed immigration, Latina youth. These were in urban, semi-urban, and rural areas across New Mexico. Of course, the urban area being Albuquerque. In total, we had 33 participants, and our work consisted of 13 individual one-on-one interviews for focus groups across three different regions with 5 to 12 participants in each of those regions. And then we did capture gender on a binary, so female, male. And then the ages here were between 18 and 30 years old at the time of data collection. Of course, this was a qualitative community-based participatory research. And our analysis process was individual cross case analysis, and it was an iterative process through a thematic analysis. And this is really where my love for qualitative research kind of came about. And after, for the purposes of publication and contextualizing the findings, we use critical race theory, centering race and racism and the experiences of these youth that they shared with us. Now, the data was collected, the data was then analyzed, the data was then put together and summarized, and then taken back to the community members through a series of different community gatherings, where these, what we call community informants, um, we took the data to them and they essentially presented the findings and through a sensitizing activity called the foot of oppression, which is a structural analysis tool used by many community organizers that kind of gets at makes you critically analyze and tries to shift the blame from personal failures to systemic barriers to answer the questions of why do these things happen to us? And it moves the conversation from analysis to having a deeper understanding of the causes to then moving to shared unity and understanding, which then brings about ideas for action and change. And so after we presented the findings, after the foot of oppression was done, the community informants confirmed the themes, and then the question was asked, what do you want to do with these changes? And so one of the changes was a policy change where where people of different immigration statuses, including DACA and undocumented, where they could have the opportunity at gaining professional licensure in the state of New Mexico. And so our research findings were used as an advocacy tool, both at the state and at the federal level. So at the federal level, it was used during a congressional hearing on DACA. And at a state level, it was used to advocate for professional and occupational licensure. And that law, at least in New Mexico, it did pass. I believe it was in 2021, or maybe it was 2020 or 2019, but that law has been passed. Okay. So, what did we find? After we went to the community members, after the policy changes, we then wrote a paper. And in the paper, we talked about our findings. So, our overarching themes were emotional and financial stress due to lack of healthcare insurance. So, our themes also confirmed the healthcare barriers that I mentioned previously through a literature search. There is also a consistent fear of revealing immigration status and viewing hospitals as a last resort, meaning that people will hold off medical care until it's absolutely necessary, until they are dying. An example of this is there was a woman who went to a clinic. She was undocumented, and she talked to the doctor and was saying that her baby hadn't been moving, and she was getting really worried, but she was really afraid of going to the doctor because she didn't want to reveal her immigration status. Well, what ended up happening is that she was on the verge of sepsis because her fetus had died. But she was nervous of going to the hospital. There's other people who have treated a broken nose, try to treat that at home before going to the doctor, and things like that. And there was, as a result of that, because of the lack of health insurance and because of fear of exposing one's immigration status, a lot of times community members go to community clinics, where there's an understanding and an internal network of, oh, they treat people like us at this clinic. Oh, they don't ask you for a social at this clinic. Oh, my friend went to this clinic. She liked this doctor here because this doctor talked to her like this, or this other doctor knew Spanish, or whatever other language. And so because of that, it's great that community members have places where they feel safe to get their care. But what happens is these community clinics are already very resource deprived. And so it creates backlogs in appointments and care. Sometimes people are waiting 3 or 4 months to see their primary care provider. I'm sure it's a lot higher now. We also saw different themes by geographic area, so including urban, semi-urban, and rural populations. So for urban, it was discrimination, family separation through deportation, and immigration trauma. Here, participants talked to us about their parents being deported, their sister being deported. An example was a pair of siblings went to school, and then they came back home, and the mother told the children that while they were at school, their father was detained. And then afterwards, what eventually happened was that father was deported. In semi-urban areas, we saw more microaggressions, internalized oppression, and education and medical access barriers. And then rural, similarly, microaggressions, high stress. And here I do want to point out the high stress could be because in rural settings, availability of healthcare centers is even more limited, which means that oftentimes people have to drive, and it's in that driving that people are worried that they may be stopped by a police officer who then may ask them for immigration status, who then may turn them over to ICE. And so that causes a lot of stress for these families too. And then they also mentioned educational and medical barriers. So the results that I want to highlight on this next slide are quotes from participants. I won't read all of them, but I do want to highlight the one for emotional and financial stress, the first bullet point. So this participant detailed that a doctor detected a tumor in her sister's brain, and they had to do surgery. And because they didn't have health insurance, it would cost $10,000. I have a feeling it's way more than that now. And so they had to go through the hospital's financial system to try and get to a payment plan several times. She highlighted 5 times here to try and get on a payment plan to make sure that the sister could have the surgery. And I just want to note there isn't a timeline on this, and we don't know the severity of her sister's brain tumor. But I also think that's an important factor to keep in mind. If it's severe enough to where it needed to be an emergency surgery, I think the urgency then is greater to try and figure something out, a payment plan of sorts, so that the family member can get the surgery, which then creates a lot of stress for these families. Okay, so then now I just kind of want to bring it back to a discussion. Um, Immigrant families, the and I will talk more about this in kind of at the end of the presentation, where being an immigrant of different immigration status is really a chronic stress. It's not something that it's okay, happens one time. I'm an immigrant this year, but I am not an immigrant these other years that I'm here because I've been here for X amount of time. It just doesn't work that way. And this chronic stress does stem from anti-immigrant and race-based bias, even in immigrant-friendly cities like Albuquerque and really like Massachusetts too. All the community members that we talked to identified mental health and well-being as a critical concern, along with the need for policy changes impacting systems of health and education, as we mentioned. Now, I do want to point out that this data was collected immediately after the first Trump administration, and now, as of January 20th, 2025, there was an executive order where hospital settings were no longer sensitive locations. And so here we do expect for things to be a lot worse now. We have seen where ICE has detained someone that was seeking medical treatment where medical providers tried to prevent them from detaining them. And this was not a lawful detainment, right? You have to have a specific warrant because there's different warrants, but they had neither. Um, and so here I'm highlighting the barriers to healthcare access for people who have migrated, right? But I want you to think of migration status on a continuum, and like I mentioned earlier, through the life course, especially because trauma in different experiences that can adversely impact health can happen pre-migration, during migration, and post-migration. Now, to highlight work around pre-migration, I'm going to present research I conducted on a longitudinal cohort study located in Central America. And so that for this, this is learning objective 3, and it was a qualitative analysis as well, titled Mental Health Among Adolescents at High Risk for CKD of Non-Traditional Origin in Nicaragua. This was a mixed methods assessment. This is part of a very large cohort study that has been going on since 2010, looking at different factors, environmental factors, specifically as risk factors for this disease. Now, I do want to point out a very brief and very basic slide for you all on the differences between the risk factors for chronic disease, chronic kidney disease of traditional origin, and then chronic kidney disease of unknown origin. I'll start from the top on either side. So age is a big factor, right? So traditional chronic kidney disease, it's around age 60, give or take. However, for CKDu, as I'll call it going forward, is 20 years old. It primarily affects males who work in agriculture, who may work with agrochemicals, pesticides, things like that, who have recurring volume depletion. So volume depletion means repeated episodes of dehydration. And this has been highlighted as a potential mechanism through which heat stress could cause cumulative subclinical kidney damage, which then could lead to CKDu. Different infectious agents, heavy metals, and heat stress. None of these are of metabolic origin, meaning that people who have, and that's actually part of the screening criteria, people who have CKDu don't have diabetes, hypertension, or don't have a high BMI. The way that we're categorizing suboptimal kidney function in our study population, given our age range being 13 to 30 years old, was an EGFR or estimated glomerular filtration rate of under 90. There is, as you may know, there is many equations to estimate EGFR. The one that we use, given our broad age range, is the European Kidney Consortium equation, the EKFC. Um, and the reason why we do this is because it's one of the more conservative EGFR equations, and it's been validated in study populations between the ages of 2 and 99 years old, and it's a race-free, I believe, sex-free equation. Okay, so for a little bit of background, CKDu is a leading cause of mortality in Central America. The hypothesis of the disease is contributed to occupational, socioeconomic, and environmental factors, as I mentioned. And keep the push and pull theory of immigration in mind as I'm going through this presentation, and as I'm talking to you about what are some of the pull of the push theories that I talked about. Well, there has been a lot of research on environmental exposures associated with the disease. There's less of a focus on the impacts of the disease on the affected communities. There is documentaries that detail CKDU in this region, specifically in Chichigalpa, which is the epicenter of the disease. However, mental health and decision-making perceptions of the disease is not well characterized in Nicaragua. So the aim of the project as a whole, was to assess renal health and environmental exposures in Nicaragua in this high-risk region. Here, I'm highlighting pictures of the study team talking to our study participants. We do take biological samples, which include blood, urine, and hair. And also, too, we have taken nasal micro and gut microbiome samples. Of course, I would like to highlight our study team. Um, they do wonderful work and all live within the regions that are affected. So the motivation for this project was to better understand mental health among people living in these areas, and in particular, analyze qualitative themes around education and employment making decisions among youth who live in the affected regions. And the bolded bullet point is the primary research question of interest. Okay, so these are some participant characteristics. We have close to 500 participants. As you saw earlier, this does mainly affect males and females. A unique feature of our study is that little over half of our study population are females, which is important because although what we found actually in a paper that we are submitting for publication on Monday, is that we do see females who also have a reduction in EGFR, regardless of employment type. And we found that for males too, although some of our findings still held. We have the different ages here. So most of them are over 18 years old, which is kind of when you start making those employment and educational types of decisions. More importantly, a large portion of our study population are students. It's important to know that the literacy level and the education attainment level in Nicaragua as a whole, it's very low. Older numbers, the reporting there is not very good as far as national registries and things like that. But the last available report, the educational attainment was around for grade 4. Now, I want to highlight these different EGFR cut points, specifically the EGFR under 90. Now I do want to mention that this was a cross-sectional example, so sample, sorry. So taking out one point in time during the study period. But these numbers, we don't expect youth that are ages within our age range to have an EGFR under 90. That's typically what you see someone that's 50 years or older. So something is happening within these regions, even among youth who are students. Um, and that's affecting their overall kidney function. Okay, so we wanted to have some questions to have a better understanding. These were the ones that we asked. If concerns about kidney disease affected your work decisions or plans, has kidney disease or concerns about kidney disease, change your decisions or study plans. And then also had a Likert scale. I still want you to think about the push and pull theories of migration here, and then what different stages of life, how social and cultural factors can affect health. Briefly, this was the we did an inductive thematic analysis to really let the data tell us what the themes were instead of applying a theory or framework to the data itself. Now, here is our results. I feel so we use a PHQ-2. If any of you have feedback on a better screening metric that's validated in Spanish-speaking populations, please let me know. I would love to learn about it. We did see that 72 participants had a PHQ-2 score of higher than 3. We did see that some of them did believe that the epidemic affected employment decisions and educational plans. A good portion of our study population always worried about the kidney health of their friends and their families. And I think what I want to get at here is the effects of chronic diseases on mental health outcomes, as well as push factors of migration. Okay, so these are the differences by PHQ-2 that we found on participant characteristics. We didn't find any differences by sex, males or females. We did find differences by age with those over 18 versus those under 18. And this was expected because, like as I mentioned, when you're 18, you start making more of those employment and educational type decisions. We then took our study population and compared it to PHQ-2 scores in the NHANES data set, and we matched it for the same year, age, sex, and Hispanic identified adolescents to make the data sets comparable, and we did not find any meaningful differences there. Briefly, these were our different themes, employment-based questions and educational-based questions. So for employment, we have health preservation, worries, deciding to not work in the sugarcane fields, and then we also have psychological and emotional impacts for education and decisions. It's important to note we did have a participant who did uh, who did die by suicide within our study population, and we have had other participants who had different mental health struggles, and they may or may not be related to the disease. So from there, we kind of took a conceptual framework. Okay, what is going on that is making them make these employment and educational choices? So it's having the awareness of the CKDu risk, which then leads you to make different financial security and educational aspirations or plans. But then there's also a psychological and emotional impact of the disease. And together they both affect your employment and educational choices. And so the conclusion that we came to is that this epidemic does negatively affect life choices and opportunities for these young adults. And I do want to highlight too that within our study population, a good portion of now we have 506 participants across the study periods, but we started with 904. And yes, there was loss to follow up, but a lot of them have migrated to other countries. And so I want this study that I highlighted was an experience of what happens pre-migration. And so now I kind of want to put it all together and synthesize the 3 learning objectives and applying a life course perspective on the framework, a life course perspective framework on this population to really understand that different legal status, socio-political climates, systematic barriers, and cumulative barriers to healthcare access for undocumented people. These all affect, or in living in a high-risk region for CKDu, these all affect different your health at different life stages. And so, an example of here on in the life course model for children who are newborns or children who are or fetuses, right? Would be there's a study out of Arizona who looked at birth weights of children whose mother is an immigrant before and after SB 1070, which was an anti-immigrant policy that was passed in Arizona, and children were born smaller to mothers who were immigrants versus children who were not mothers to immigrants. And they were able to attribute that to the passing of this law. And so I want you to think of immigration and immigrant health on a continuum, especially because health states are migratory, meaning that a person's health state from their country of origin, it just doesn't magically reset when they migrate to this new country, right? It goes and it continues with them. And sometimes it could get worse. Like let's say we have one of our study participants from Nicaragua who has an eGFR of 90, right? Then they come to the United States. Um, they have different experiences as they migrate and as they begin working, but they work a low wage job. And they have a history of poor mental health, right? Maybe they have schizophrenia, or maybe they have undiagnosed bipolar disorder. And I want you to think of the aggregate health effects of having those experiences and from their country of origin to then the experiences they have here once they migrate to then when they try to get access to healthcare. It really is a continuous exposure that is shaped by individual and political factors across the lifespan. And traumatic experiences that occurred during migration have long-lasting impacts. Children's mental health as a result of family separation is forever changed, where there's been reports of children who are no longer able to bond with their parent because they were separated and the child believes that their parent abandoned them, and that can cause a lot of different behavioral issues. And like I mentioned before, health risk factors and experiences in country of origin serve as drivers of migration as well. In this concept that I called a migrating health state. And I don't know if you all want to take a picture of this. This is kind of more of a resource for you, providers and immigration enforcement. It was part of one of the links that I shared with you, just to kind of safeguard different safeguards and things that you can do to keep yourself and your patients protected as you provide care to them. So the last thing, I just want to acknowledge my funding sources, the NAEHS T32 doctoral training grant and the Robert Wood Johnson Foundation, as well as my advisors and mentors, Dr. Tom Chavez, Dr. Jessica Liebler, Dr. Patricia Fabian, and Dr. Madeline Scammell. And I want to thank you for your time and attention, and I'm happy to clarify or take any questions.
Thank you so much, Selena. That was a wealth of information linking mental health and health here. And yeah, please, anyone, if there are any particular questions or comments that you would like to make at this time, please feel free or to put into chat. You made quite a progress in all your work here from the very beginnings and and really bringing in policy pieces into the work that we do. So thank you so much. If
Thank you.
yeah, thank you for joining us today. And I will go ahead and close at this time.
Great. Thank you.
Thank you so much for your presentation. I really can't think of anything more timely, and we certainly appreciate your personal, you sharing your personal story with us. So thank you so much. I think today this is, heavy on a lot of our hearts. So
Yeah.
thank you.
Thank you, Angelica. I appreciate it. Thank you so much, everyone. Have a wonderful day. Thank you, Tom.